right. For the sake of time and making sure that we're kind of respecting your time and we can get on going on with the session. So welcome everybody to AO Link Session 7, Unlocking Orthopedics. This is our seventh in a 10-part series, so we appreciate you logging on and tuning in to this session. So again, Fracture Friday is a collaborative effort between the AO North America and the Medical Students Orthopedic Association or Society in order to provide bite-sized information about orthopedic trauma cases and orthopedic trauma knowledge for medical students to prepare for away rotations and residency. Please check out both the AO Trauma North America as well as MSOS websites for Fracture Friday videos. Those will continue to come along down the pipeline. AO North America is an organization that can grow your skills and expand your network. There are numerous opportunities for folks in the AO, so consider being a member, and you can use the QR code to join today. AO Link is a online webinar platform for medical students to gain knowledge about musculoskeletal and specifically orthopedic knowledge that may not be supplemented in their medical student education in order to prepare themselves for away rotations, home rotations, and just in general on orthopedic knowledge. We'd like to acknowledge the AO leadership for their continued support for AO Link, Dr. Lee, Dr. Kapatkin, Dr. Aker, as their continued support of the AO Link platform has allowed us to continue to give you these lectures today. Again, Dr. Marchand and myself are the faculty and co-chairs of the AO Link committee, and we will be joined today by Dr. Skamitzi out of the University of Chicago, and potentially by Dr. Young out of El Paso, Texas.
Just made it.
There we go. Here he is. Dr. Young is fresh onto the call and can add some important information as the former chairs of AO Link.
Fresh off a distal humerus non-union with both plates buried about 5 millimeters under the bone.
There we go.
Was tons of fun.
Was it a polytrauma?
No, it was a non-union from somebody else.
Got it. Okay. All right. These are our financial disclosures. Again, there's 10 sessions. Make sure you attend to all to get your final merit badge. We have 3 more coming up after this. We'll go at the end. AO Milestones is an online platform to help improve your surgical proficiency. It's a unique individualized learning experience online to help master your medical knowledge, anatomy, and real-world scenarios. So consider using this QR code to use that. So here we go. We'll get into the session today, polytrauma, improving patient outcomes. The learning objectives today are to discuss the evaluation and initial management of polytrauma patients, understand the orthopedic priorities in the polytraumatized patient, and understand parameters contributing to definitive versus temporizing fixation for patients. So, what is a polytrauma? You may ask yourself, well, how do patients get the marker of a polytrauma, or what is it that makes someone a polytraumatized patient? We use something that's called the word polytrauma, but it's not really often described. We kind of just say, well, that person looks really injured, so they're probably a polytrauma. So the generic definition is injury to multiple extremities and or organ systems. So that can be fractures, brain injuries, spine injuries, abdominal injuries, chest injuries, and that's just to name a few. It's lots of organ systems that are involved in multiple organ systems. Each extremity is basically an organ system. And then, as you guys learn in medical school, all the other organ systems can be involved. So if there's traumatic injuries to any multiple portions of that, then a patient can be considered polytraumatized. But you may say, is there a more specific way? How do we really define this? Well, in research, we oftentimes use what's called the injury severity score or the ISS. It's often referred to as the ISS. And what this is a score that basically categorizes the injury to the patient so that we can tell how injured a patient really is. So what it is 9 body regions, including the head, the thorax, the spine, upper extremities, lower extremities, up to 9 body regions that are predefined. And then each body region has a 6-point score that's the same for every body region. And it goes from 1 to 6, where 1 is minor and 6 is unsurvivable. 5 is major severe. And so, what you do in order to create your ISS score, your injury severity score, is you take the highest, you label all 9 body regions, and the 3 highest scores, you square each one of those and add them together. So it's a little bit confusing, but if you square the 3 highest scores and add them together, if it's over 15, then a patient would be considered polytraumatized, and most research studies for can be considered polytrauma. But Dr. Marchand, you do a lot of research, but you also do a lot of clinical work. Is there any time you're using this marker in your clinical scenario? Is this an important thing in clinical medicine, or is this mostly just for us to help do research to drive polytrauma research?
This isn't ever something in clinical medicine that I would like hand calculate or determine and allow it to impact decisions. That being said, it is basically automatically calculated in our EMR now, and it is something I will look at to maybe get a sense of how severe or critically injured somebody is. And because in our EMR it kind of outlines which body regions they've used to calculate the score, it can give you a sense of like what injuries are driving their injury severity score. But for the most part, this is primarily something that is utilized in research to help stratify patients and compare like groups, albeit an imperfect system. Because if you look at it, there are clearly body organ and areas that will drive your outcome more than others. And the scoring is not necessarily weighted to reflect how that may be, i.e., head injuries are a primary driver of patient outcomes in the polytraumatized state. And it's not like head injuries are necessarily weighted any more heavily in the injury severity score than, say, a severe injury to an extremity.
Dr. Scamitzi, do you do anything different?
No, I basically do the same thing as Dr. Marchand. I think useful for research, but it's not really something that I calculate for any given patient. I think our EMR doesn't even spit out an ISS that's at least readily visible. So I think, if someone does bring it up, it can give you an idea of how injured a polytrauma patient is, and that might kind of tip the scales one way or the other and how you treat that patient, but it's not something that I typically am calculating for any patient that's kind of being presented.
Perfect. So just something to know about when you hear ISS, that's what it's talking about. But again, the clinical relevance may not be as much important as the research importance. So when you're talking about polytrauma patients and polytrauma evaluations, this is largely done at most level 1 trauma centers by the ATLS. So I have a couple caveats about this lecture. This is not meant to replace ATLS. The ATLS system is a very well-defined and well-run system to teach patients or teach providers about the trauma evaluation and trauma care. This is merely to teach you that this is how people in polytrauma situations are evaluated. And we'll go over it briefly, but again, it is not meant to replace or to cover everything that ATLS does. And the ATLS system was created by an orthopedic surgeon. That's kind of not oftentimes a known thing, but the ATLS protocol was derived by an orthopedic surgeon who crashed his plane in the Midwest, and his family was all taken to different hospitals, and they all received vastly different care. And he felt that the outcomes of each of his family members was based on the quality of the care that was given at the initial evaluation, and then decided that there needed to be a more standardized evaluation of trauma patients. So that was certainly a unique thought process at the time and was not as long ago as you thought it might have been. And so again, we as orthopedic surgeons like to take credit for ATLS, even though largely most of us were not involved with it. Um, ATLS is a very defined system. So it starts with a primary survey, and we're going to go over this a little bit more detail, but it starts with a primary survey, goes through a secondary survey, includes a portable AP chest and pelvis, a FAST scan, which stands for focused assessment using sonography for trauma, and a CT scan occasionally. Adjuncts including monitoring, blood work, ABGs, resuscitation. The patients are getting resuscitated in the trauma bay by the provider who is running ATLS. And then ultimately definitive care. So the primary survey, you're often probably already heard this if you've been on rotations or you've been in the emergency department. We got to take care of the ABCs. We need the ABCs. So what does the ABC stand for? Well, first, it's airway. So, airway is the actual tube that gets the air to the lungs. It can sometimes be really confusing when we talk about airway and breathing because it sounds like they're very similar and they're very connected, but they're very different things. So, airway is the tube that gets the air to the lungs. Breathing is the ability to inflate the lungs and be able to get oxygen from the airway into the circulation. And then circulation is being able to get the oxygen out to the organs. So basically, ABC is can you perfuse your end organ systems? Can you perfuse your legs? Can you perfuse your liver? Can you perfuse your heart? Can you perfuse your brain? The D stands for disability or neurostatus. You can think about it. Does a patient have a reason to have a blood pressure or some vital sign changes based on a spinal cord injury or some level of neurologic deficit that's driving some of their acute vital sign changes? And then lastly, E is for exposure. Patients need to be disrobed and effectively naked in the trauma bay so that we can evaluate the entirety of the body, look for penetrating injuries, look for deformities, look for reasons that they could be bleeding. There's a lot of reasons to be able to examine the whole body. Patients are rolled in a very safe way for their spine on the back so we can evaluate the back. And then they're kept warm. I think Dr. Scaminci, talk about a little bit about we cut the clothes off these patients and then they're sitting in the trauma bay. The ER has kept the trauma bay at 60 degrees. What are some things you can do as the orthopedic resident? Your PGY1, you're an MS4, this trauma patient sitting there totally disrobed and we're ending the primary survey. What are things you can do?
I think for the second, at this point, you can really start to participate in the secondary survey if the primary survey has all been completed. And I think the orthopedic resident and medical students can be really heavily involved in this. And you really want to palpate all the extremities. So from shoulder to wrist and fingertips, and from pelvis all the way to feet. Move all the joints. You want to palpate for crepitus and feel for any crepitus with range of motion of the joints. With part of that exposure, when the patient's rolled, you also want to palpate the spine, look for any spine injuries that can also be present in polytrauma patients. And then for, if you have already have your AP pelvis, then you already know of a volume expanding pelvic ring injury, you also want to do a rectal exam or a vaginal exam to rule out an open injury. Also look for wounds kind of in the perineum and those types of things. So lots of things to try to focus on in a quick amount of time.
Yeah, the secondary survey is extraordinarily important in finding kind of the next level things that can hurt a patient. The ABCs can kill a patient quickly. If you can't breathe and circulate oxygen to your body, obviously that can kill you quickly. And that's why it's the primary survey and the most important thing. Get a protected airway, get them breathing, and make sure they're oxygenated. Those are the most important things. And then we start to find the other things that can really drive outcomes of polytrauma patients with a secondary survey, like Dr. Scamitzi said, extremity injuries, spine injuries, abdominal injuries. This is in between the primary and secondary survey. They're doing a fast exam again, focused assessment using sonography for trauma. It's an ultrasound of the belly to look for fluid to see if there's an abdominal injury. These are all things that we're doing to try and evaluate the patient as quick as possible, but as thorough as possible. This shouldn't be a very quick exam that's not very well done. It's got to be a very focused exam that's very well thought out, but it's quick so that we can move through these things to try and help the patient and get them into the appropriate level of care. And then the last thing I would talk about is when patients are naked in the trauma bay, they're cold. And we all know that cold patients do poorly. So keeping them warm as much as possible, warm blankets, keeping them covered once we've evaluated the extremities. They don't need to stay disrobed. They don't need to stay cold. Once we have a kind of initial secondary survey of the patient and we know what the injuries are, make sure we are warming them up so that we can make them less coagulopathic, less likely to bleed. The next part of the evaluation is an AP chest and an AP pelvis. This is normally done, back in the day you had to roll patients, but now they come in on these trauma stretchers that have slots for the I mean, they're perfectly positioned. They have slots for the film that goes in. There's sometimes even an X-ray machine in the trauma base, drops down, takes a pelvis, drops down, takes a chest. This is to evaluate for injuries that can kill people quickly. Volume expanding pelvic ring injuries, like Dr. Scamitzi said, hemopneumothoraces, tension pneumothoraces. These are quick things that can be evaluated on chest x-ray that could be easily taken care of in the trauma bay that can save lives. That's why we get these things to rule out certain injuries that can be very easily fixed, that can totally change patients' outcomes. All right.
I just wanted to bring up that there are a couple publications out there now about how fewer and fewer AP chest and pelvic radiographs are being obtained in the trauma bay. And there's not much to say about it other than that data is out there. It is becoming less common without a lot of evidence to support the change in practice. And so for the med students that are at different hospitals and rotating on different trauma services, when those imaging steps are skipped, it'd be worthwhile talking to the residents about why that may be, and not necessarily the orthopedic residents. You could be a medical student that's rotating on the general surgery trauma service. And these would be excellent points to bring up to help generate some discussion and help inform yourself. Perhaps your hospital has an excellent protocol of if patient has X, Y, and Z, we skip the chest, or if they have X, Y, and Z, we skip the pelvis because we're not concerned by what may be happening in the pelvic ring. So it's sort of fascinating to see that trend evolving, but it's certainly happening and something for all of us to keep our eyes on. We don't, at my center, always get both of those images, but I do find them incredibly helpful, and I know they can be obtained expeditiously and at low expense. So it's hard for me to understand completely the rationale for skipping them.
Dr. Young, you guys getting both pelvis and chest on every trauma one?
I prefer to, but it does. I'll be honest, it doesn't always happen.
Dr. Scamitzi?
Yeah, same at our place. I think it's been a change that's been happening more and more recently, and something that we've all talked about in our group. And we also would obviously prefer to have the AP pelvis and chest in the trauma bay, but I think a lot of patients are getting whisked away to CT scans, and that's often used as a substitute.
Perhaps the setting where I can understand them being excluded is for, say, isolated penetrating trauma. Um, that sort of makes sense, or at least I can rationalize why that might be. But I think we all know it's very rare that we know all the circumstances surrounding a trauma or an injury. So anytime that you're going to make an assumption that something is isolated, um, you put yourself at risk of missing something important.
Yeah, I agree. I think Dr. Scamitzi touched on it briefly. The accessibility and ease of getting a CT scan these days have largely driven trauma surgeons, and this is speaking from the heart, so I apologize to the general surgeons, has replaced the need in their mind for an AP pelvis because it can so easily be obtained. But oftentimes, not oftentimes, but sometimes it would be more helpful to just have an AP pelvis, and we can put people in sheets and things like that we'll talk about before they go to the CT scan. So again, I do think it's important, but I really love Dr. Marchand's point about asking, you now know that all trauma ones are supposed to get an AP chest and pelvis. So gently ask your trauma surgeons, hey, I learned that AP pelvises are supposed to be obtained. What about this patient was change your mind about getting that? Just as we talked about in our first session, don't trauma surgeons have very specific reasons for doing things, so they have a reason. So don't make it out like they didn't do the right thing. So we have a consult. We have a trauma one ETA here now. For those of you that have been around the residence, this is not an uncommon page that happens. You're just walking around the hospital doing some things, and then all of a sudden there's a trauma one. Depending on your hospital, you may or may not have to respond to trauma ones when you're an orthopedic resident. I worked at a place where every trauma one needed to be responded by an orthopedic resident in the bay. So this was always fun. You had to start running yourself around the hospital back to the emergency department for the one that was here now. So this is a 24-year-old male. This is the EMS telling us 24-year-old male involved in a motorcycle crash. He was found in the back seat of a van. He has a blood pressure of 104 over 60 and a heart rate of 114. And they did obtain an AP chest and an AP pelvis. Dr. Marchand, what are you looking for on an AP chest? Why do you care about an AP chest as an orthopedic trauma surgeon?
Yeah, it's funny you asked because I was just advocating that we get these. The truth is, we're probably as orthopedic surgeons not the best at looking at plain film radiographs of the chest, but I do look at them when we get them, and there are obvious things that I'm looking for. So, being a skeletal surgeon, I usually start with a skeleton. So I'm looking at the clavicles initially, as well as the AC and SC joints when they are visible on the plain film radiograph. Here you can see this patient does have a clavicle fracture. So as soon as I see that, I start to kind of hone in on a shoulder girdle because you can see many things associated with clavicle fractures. So after getting to the clavicle, look down at the scapula and then also the rib cage. My thought being there is nothing acutely for me as the orthopedic surgeon to do, say, about rib fractures. But it may change the way I manage the clavicle fracture, believe it or not, moving forward. And it may give me some idea to the level of lung injury that this patient may have, which is contributing overall to the picture and the timing of managing other injuries. So I would go clavicle, scapula, ribs, which I don't see anything in either scapula or the ribs here, just the clavicle fracture, which is helpful. Sometimes if there's a real gross abnormality in the spine, you can see that too. Say there is a subluxation or phalange dislocation that may be obvious on a plain film radiograph, although exceedingly rare. And then I'll always do my best to take a quick blush at the soft tissue structures, primarily the lungs, mostly looking for that radiolucency that would suggest a pneumothorax. Although, again, I'm definitely not nearly as good as the general surgeons or the radiologists at finding those. And then looking at kind of the soft tissues in the center of the chest to see if there's any sort of midline shift or something that may suggest or be another clue that there is air in a lung or a pneumothorax, something along those lines.
Perfect. That's awesome. I think that we can all agree that as orthopedic surgeons, we are not going to be the ones that are on the line for the final read of a chest x-ray, but we can certainly take a look and notice large pneumothoraces, whited out chests. You can see things that can really change your management and outcome of patients and say, okay, this patient is really sick, or this patient's chest x-ray looks fairly normal to me. There could be some abnormalities, but maybe the chest isn't the thing that's driving their final outcome. And then here's the AP pelvis. Dr. Scamitzi, what's what is the belt? What is Santa's belt around him? What is that kind of coil thing?
Yeah, so I think a lot of patients show up with one of these devices. It's a pelvic binder of some sort that's been applied in the field. And a lot of times patients, in the field when they have some hypotension and tachycardia, the assumption is they've had some blunt injury. The assumption is they may have a pelvic ring injury that is a source of that hemodynamic change. And so they get a pelvic binder applied. And they can show up with these, and sometimes they were necessary to be placed, and sometimes there are things that we can remove shortly after their arrival. Um, I think that's what we're seeing here.
For sure. Dr. Young, is there a harm to the EMS folks just putting a pelvic binder on everyone that seems like a level one trauma?
Well, we talk about like some of these lateral compression injuries, and maybe it's going to make it worse. But really, at the end of the day, I think if somebody's bleeding and they're hypotensive, you certainly want to contain the volume of the pelvis. And I'm not going to be mad about it. I would say that.
Yeah. I think that's totally the marker. There are sometimes people come in with unstable pelvic ring injuries that weren't volume expanding that are might be making the patient more uncomfortable being in a binder, but a binder can save someone's life, and it has very few downsides other than maybe some patient discomfort. You can argue that potentially an EMS person, if they cinch it too fast and too tight, could puncture a hole in the bladder, but I would find it hard to believe that that's the case. That I think these are generally a very safe device to use that can really save patients' lives. Dr. Marchand, when would you advocate for us to, this? I think this AP pelvis looks pretty good, dude. Would you agree? I don't really see anything wrong with it.
Yeah, I think in stay tuned for future AO Link lecture where we'll talk about pelvic imaging. But this, in general, this is a quality trauma bay AP pelvis. I'm looking basically at the symmetry of the obturator foramen, the iliac wings, and then looking back at the spinous process just to make sure that the film is not too rotated, which this was one isn't. It also captures the entirety of the hip joint, the proximal femurs, as well as the pelvic ring. Like no part of anything that we really want to see here is cut off. So we can go into more detail, and we will in a future webinar. But in general, the rotation's good and everything you want to see is on the film. Two thumbs up for me, especially for the trauma bay, where these things are moving quick and you're not really taking your time and shooting and reshooting to get the perfect shot. This is pretty well done.
So when should we take this binder off?
Yeah, that's a really
I
good
don't see an
question.
injury.
That's a great question. I don't see an injury on this film. So the trick here, right, for the medical students on tonight or those early in their training, is that a binder is really good at reducing the volume of the pelvic ring. So good that you could have a very severe pelvic ring injury, say an open book pelvis, or like an APC type 3 injury, where you'd have complete diastasis of the pubic symphysis and essentially a dislocation of the SI joint. The binder is so good, it could reduce your hemipelvis or both sides of your pelvis into an anatomic position and basically hide those injuries. So, in somebody who presented to the hospital and was hypotensive and tachycardic, and mind you, this is a 24-year-old. So for me, that's kind of a critical point because the younger and the healthier we are, the longer we can maintain our blood pressure at a lower heart rate. So as soon as you start to see these soft signs of hemodynamic instability in a younger person, I get really worried because it means they're compensating a lot. So in somebody who is tachycardic and hypotensive, I'm worried they could have had a pelvic ring injury. I'm not taking this binder out until I have CT scan imaging of the pelvis that I can review to make sure I'm not seeing any evidence of soft tissue injury around the SI joint or symphysis. So that would primarily be air, soft tissue stranding, or blood on soft tissue windowing of the CT scan. And even if I had all of that information, it was all normal until the patient is stable and in a place that they can be monitored in a safe fashion with good IV access, the binder's not coming off. For me, that period of time is usually 24 to 48 hours. But I'm sure that there are centers that Greg and Taylor, where Greg, Taylor, and even you work that do it differently.
Y'all do anything differently, Dr. Young?
Generally, yeah, we'll keep a binder on for quite a long period of time, but we do try to loosen it and see what the pelvis looks like, and we're bedside, watch the vitals, things like that, and then retighten it if it's just crazy wide displaced or they have vitals changes, sort of thing. But it does get tricky in those really head injured patients. Sometimes I'll switch from a binder to a sheet because I do feel that the sheet distributes the forces a little bit more evenly. Obviously, you can tape the legs together. You don't want to give them a thigh compartment syndrome or anything crazy, but also internally rotating the feet and the toes, all those different things to try to limit that pelvic volume. But still, um, sometimes it's hard if these patients aren't clear because of really bad head injuries or something.
Anything differently, Dr. Skaminski?
No, not much different to add. I think, I don't have like a set timeline, but in general, I try to minimize the time that a binder's on to something within a couple days and transition to a sheet. But ta as far as taking a binder off, definitely want to do it like Dr. Marchand said in a controlled setting where you have IV access. And in a patient like this, I agree having a CT scan where you don't see any CT evidence of a pelvic ring injury is useful as well to kind of just help confirm that you're not going to disrupt a good reduction on a previously massively displaced APC pelvic ring. So
Yeah. So I think the keys to take home from this is binders are largely helpful for patients. Sometimes they don't need them. If you are going to take them down, I would suggest that you do have fluoroscopy and or radiography ready for you. So when you loosen it, you can take a shot of the pelvis so you can see if you have there was an injury that was masked. And two, you are doing it in a very controlled setting, and people know that you're doing it. The ICU team, the general surgeons, everyone knows it's a very controlled manner. You're saying, I am now taking down the binder, and there's nothing else going on. You don't have a subclavian being put in. There's not splinting a leg. This is the only thing the team is focused on is you taking the binder down so that you can monitor blood pressure. You can take an X-ray, and everyone's focused on the patient. And then, lastly, if you're cutting a binder, if you're gonna make it so that the binder cannot be put on, make sure that there's a sheet available or some other binder that's readily available under the patient that can quickly be put back on. So if the pa you would be shocked sometimes you can take a binder off and a patient's blood pressure can go from 125 over 80 to 40 over 20 in 2 seconds when you take these binders down. So you want something that you can quickly put back on. So there's just a little bit of things you want to make it a very controlled setting to take off. This isn't something that's like just go take the binder off and run away from the patient. So this patient had was a GCS of 11. This was our polytrauma. You'd say from this, how are they even they have a clavicle fracture. This is like this is a non-operative injury. This is an ISS of 1. But GCS of 11 maybe has a head injury, maybe doesn't. And can't protect their own airway, so they get intubated. You see an endotracheal tube here. And then we do a secondary survey, and we notice deformity to all 4 extremities. This patient has bilateral femur fractures, upper extremity, lower extremity fractures, and you notice that they don't have a pulse on their left lower extremity. It's not Dopplerable, it's not palpable. And so this patient has fractures to nearly every bone in their extremities. So this is where someone starts to become a polytraumatized patient. So we're going to get into the care of that a little bit, but we're going to talk about why does this even matter? Like, why can't we just kind of splint these patients? Like, what are we trying to prevent in these polytrauma patients? Well, you can see that all 3 of these complications end in death, and that's what we would like to avoid. There are a few things that orthopedic surgeons can really be involved with to save a patient's life, truly save a patient's life from death. And this is one of them. Polytraumas, you can really affect a patient's care. So complications from polytrauma include multi-organ dysfunction syndrome or multi-organ failure. It comes by lots of different names, but it's an ultimate sequelae of a lack of perfusion and or damage to vital organ structures in the body that leads to death. ARDS or acute respiratory distress syndrome is a terrible complication from polytrauma where the lungs are basically unable to oxygenate the blood. And at some point, some patients go on ECMO or extracorporeal membranous oxygenation. They have an artificial lung basically oxygenating their blood because their lungs are so filled with inflammatory tissue that they can't even pass oxygen across their alveoli. And then hemorrhage. Patients can bleed to death. I mean, Dr. Scamitzi, we talk about this all the time, kind of where can patients bleed to death in a polytrauma? That seems a little crazy.
Yeah, I think, there's lots of places patients can bleed, but I think the type of bleeding you're talking about that can lead to death, so a massive amount of hemorrhage typically happens in a few places. So in the thorax, the abdomen, and usually the thighs are kind of the first places we think of as spaces that can really occupy and contain a large volume of blood and where people can bleed out significantly without any outward signs of it. So I think those are places to be suspicious of initially.
Yeah, so I think totally thorax, thighs, that's bilateral femur fractures. That's probably where this patient, didn't have an obvious pelvic injury, but is hypotensive and tachycardic, probably lost a lot of blood in the thighs, abdomen, pelvis. And then the last one we talk about is the kind of the floor. Like it can bleed out of the patient. There's nowhere it's going otherwise to the floor, to the out of the patient. And so those are a lot of places patients can bleed a lot. And our goal is to minimize that. There's a lot of things we can do as orthopedic surgeons to help prevent this, and we're going to get into it a little bit. So in orthopedics, we used to abide by this thing called early total care, where we thought every fracture needed to be fixed as quickly as possible so we get these patients back up and moving, and this was best for the patients. Then we started to learn that maybe we're maybe we're actually hurting patients. We were doing too much surgery. They weren't quite ready for it. So now we thought about, well, maybe we should just stop. Maybe we should just temporize everything. Wait till they're totally better, and then we can get to each fracture. And then we started to say, well, maybe that's not actually it. Maybe we're actually hurting people doing that. Maybe there's some fractures that do need to be fixed that could help patients. And then they need to be resuscitated appropriately. And so we talk about early appropriate care. So early total care again was every fracture just get fixed as fast as possible. Stabilize all the fractures definitively. But this can be dangerous in under resuscitated patients. Sometimes patients don't have the blood status to undergo 3 nailings, to do 2 nailings of their femur. Sometimes patients can't undergo an acetabulum surgery for 8 hours because of their resuscitative status. So they just need external fixation. Damage control was just put X fixes on everything, temporize them. They allow for the in physiology and improve, give them resuscitation, let the blood go in, let them just stabilize and settle down. But sometimes, while we are providing little surgical bleeding, patients actually do better if they get some fractures fixed. And then we can avoid what we learned about from early total care was this second hit phenomenon. So, Dr. Marchand, what do you understand the second hit phenomenon to be?
I think there are two things that people are referring to when they refer to the second hit. So I'll start with what I think the second hit should be in reference to because it makes the most sense. So there's this idea that at the time of your trauma, you have your first hit, right? You have this inciting event that causes injury. In the setting of talking about polytrauma patients, we're talking about injury to multiple organ systems and or extremities. That creates an inflammatory cascade, all right? That acute inflammatory cascade does reach a peak really quick, like within hours of the injury, and to some degree starts to resolve, at least that short-term inflammatory response. The second hit, in my mind, refers to a secondary insult that is typically iatrogenic that will cause a repeat inflammatory cascade. So that could be a big surgery of any sort, or a period of prolonged hypotension that wasn't treated appropriately while the patient is in the hospital. So, like a second hit is a secondary insult to the patient that is typically iatrogenic, usually surgically oriented. But there is also this idea of a second cascade or a second wave of inflammation that happens in that kind of 24 to 72-hour period where patients have that initial spike of their inflammatory cascade, it starts to cool off, and then there's a secondary insult. I guess the best way to describe this to people, or the way that I think about this, is like, say you have a severe ankle sprain. I think this is pretty relatable for many people. You'll get some immediate swelling and bruising, and it will really hurt, and it'll hurt that night. But the next morning and the day after, like that 48-hour period, is where the swelling will typically sort of reach its max. That's sort of that secondary inflammatory response cascade to an isolated extremity injury. And I think of polytraumatized patients in the same way. It's really important because historically we thought after that sort of initial cascade, there was maybe a short window where it was safe to operate on people. But then once you kind of got 48 to 72 hours, between then and that 1 week mark, it may not be that safe. And there were periods of time where, in fact, we were completely avoiding surgical intervention for patients in that time window, even if they met all the other markers of resuscitation and clearance for the OR. Things have sort of The pendulum has sort of swung back to this concept that you brought up to everybody, Pat, of like early appropriate care. So I think we pay less attention nowadays to these like very strict time points, like 0 to 8 hours, and then they're fine from 8 to 48, but then nothing from 48 to 96 or whatever. We've moved a little bit away from that and more into like looking holistically at the patient for signs of end organ damage and end organ recovery if it was damaged at that initial insult, and making decisions kind of on a case by case basis.
What if somebody has like a terrible chest x-ray, right? And you're at that 48-hour mark, and then their lactate's fine, things like that. They look like they're resuscitated. Do you ever worry about reaming a long bone when their chest, with their chest x-ray looking pretty crappy?
I personally, I'm so curious to hear everybody else's thoughts on this topic, Taylor. It's an excellent
Yeah.
question. So I personally am very worried about that, but a bad looking chest X-ray, in fact, won't keep me from going to the OR because the best data we have is that the sooner you fix long bones, the better somebody's chest does in the long term. So
Right.
sure, there's going to be some initial insult at the time of surgery from the reamings, the pressurization of the canal, and fat embolus making its way to the lungs and potentially the heart. But the downstream effects, if you can kind of make it through that, are beneficial. And there's a great study that I got to bring up because Pat always keeps referring to me as the research person on these calls, which I'm not really that big of a researcher for everybody listening. But there's a great study that I think people
Yes.
very rarely reference. And it was a study done in 89, and the author's last name is Bone. So it's like the best orthopedic study ever, right? So it's JBJS Bone et al. 1989, where they randomized polytraumatized patients with femur fractures, not hip fractures, like femoral shaft fractures, to early or delayed management of their femoral shaft. And the femoral shaft, patients that had early treatment of their femoral shaft with intermedullary nail placement, they got off the vent sooner, spent less days in the ICU, and got out of the hospital quicker. So that doesn't completely answer your question, Taylor, because it's not like all those people had crummy looking chest x-rays. So you got to think about it. But in general, I think of stability for long bones as something that improves your respiratory status, not technically worsens it, although it certainly can, and there's a risk there.
Yeah, I think the take home is that the femur is connected to the lungs, right? On some level. And so you just have to be mindful, maybe look at vent settings, talk to your trauma team, really be clear about what you're going to do in the OR too, for sure. And you did bring up fat embolism. There was a question on that. I would say it's not super common, but certainly something you start to have to worry about if you're reaming multiple long bones. Do you guys think, what do you guys think about fat embolism? Do you worry much about it? I would say I haven't seen it commonly personally.
Dr. Scamitzi?
Yeah, I mean, it's definitely something I worry about it. I didn't quite catch the last part of your question, but in multiple long bones, I think it is something to be aware of. And if you kind of, I had it actually happen more in pediatric patients or younger patients. I don't know if that's just a sample size thing for me or what, but I think with multiple long bones, if you do see people start to have, respiratory or cardiorespiratory changes when you're reaming or pressurizing the canal, definitely maybe consider holding off or going to some type of temporary stabilization.
Yeah, I mean, I think all of us have one story of someone who in their clinical practice got fat emboli syndrome, and it really affects you. It's a terrible, terrible problem, but it's highly unpredictable about who gets it. It's not really something I could have predicted that the one patient I had got it. But it is normally younger people. But I think you hit the nail on the head, Taylor. It's a multifactorial decision to nail a femur in someone who has ARDS or has a bad looking chest X-ray. It's vent settings, it's clinical settings. It's not just a bad X-ray. It's their vent settings are going up, their PEEP's going up. So maybe that's not the person to do a nail. But their settings have been largely the same. Maybe they're going down a little bit, then person may be. So certainly something to be aware of, but I think it's a vastly, like you said, talking to multiple teams and seeing what all the other clinical status is.
Just one more comment to piggyback on that. I think another thing that I think is maybe important for the students to recognize, we have all these thresholds that we kind of use to help guide us in terms of whether we're going to intervene with a definitive surgery or something temporary for like a damage control X fix. But Dr. Kellum kind of mentioned the trend is kind of really important and being aware of the trend and how things are changing and not just a single snapshot of what those lab values or vital signs are, I think is really important. And I think that's something that, early on in my med school days, I wasn't aware of, but something to keep in mind for all the students.
So we were joking at the pre-meeting that we may not have enough content to make it to 8 o'clock. We thought we'd be maybe just a hair short, but here we are at 8:45, and we haven't even made it through halfway through the presentation. So wonderful conversation, great questions. Thank you guys for asking these. They're super helpful. I know there was one question about pelvic binder and what injuries may or may not benefit from that. And so we're going to get to pelvic binders in just a second. So early appropriate care is using a lot of this, using trends, using other markers to see whether patients are ready for some type of definitive fixation prior to just letting them wait until they're totally better after a week or two. We oftentimes use pH. We use a base excess of a negative, which oftentimes you'll hear either base excess of negative or a base deficit. And that'll be a positive number. So it can get a little confusing on that one. Or a lactate less than 4. These are all numbers that are things that will be markers of stability for patients. So this is a 24-year-old male, our consult that we got. He has multiple extremities. His lactate's 13.5. His base excess or his base deficit is 18. His pH is 7.02 and his injury severity score is 57. These are his injuries to all of his extremities. And so this is just something that you will see oftentimes in polytraumas. This guy is polytraumatized. So principles for polytraumas: life, limb, function. We use this all the time. You need to save a patient's life. If that requires taking someone's leg with an amputation because they are, I actually had this clinical scenario last month of the extremity is somewhat dysvascular. There's muscle that's dying that's causing them to go into kidney failure. They're not able to get off the ventilator. If an amputation thinks you'll save their life and more of their function, then you sometimes have to do that. The life comes first. If they're doing okay, but the limb is what you need to focus on, then you need to do all you can to revascularize and get that limb back into function or get that limb to survive. And then after that, it's function of the limb. So obviously, as orthopedic surgeons, we're focused mostly on the extremities, but then you start focusing on the function. So this patient had a dysvascular leg. The left lower extremity had a popliteal artery injury. He underwent external fixation and a procedure to return the blood flow, and then fasciotomies for reperfusion syndrome. I guess we can briefly touch on, what's the role of the orthopedic surgeon in the dysvascular limb, Dr. Scamitzi? Where do you see yourself in managing this patient?
Yeah, I think this is kind of a difficult problem that is difficult to manage at a lot of institutions. But I think with a dysvascular limb with an orthopedic injury, you really want to be able to provide some sort of stabilization to the limb before any definitive revascularization procedure is performed. So kind of think about it like if you're building a house, you want to build the foundation before you start connecting fine electrical wire. I think a lot of times, we're working with our general surgery and vascular colleagues. They want to go ahead with a vascular repair before any orthopedic injury has been pulled out to length or any provisional stabilization has been applied, which can be a problem because then when the limb is restored to its anatomic length or where it needs to be, that then their fine vascular repair can be stretched or disrupted, and then they need to kind of start over. So I think ideally the role of the orthopedic surgeon is to provide some sort of stabilization, usually an external fixator like you have here, and allow some sort of provisional stability for then vascular interventions.
Yeah, I think briefly the other thing is a shunt. Is sometimes we talk about it's a temporary a supply of blood. You put an IV tubing basically between the two broken ends of the vessel in order to return flow quickly, and then you have a little bit more time to do a better X fix so you're not rushed to get blood flow back, and then the general surgeons or vascular surgeons or whoever does that procedure at your hospital can restore flow through a definitive manner. So this patient undergoes definitive fixation of their extremities over time. And these are the surgeries the patient had. In their initial hospital admission, they almost underwent a surgery every other day for almost an entire month. This is an extraordinary onerous process on the surgeons, the team, the family, the patient, the nurses, the care managers. I mean, the entire hospital system is stressed by these patients going to the operating room every other day, every third day. Patients start to make progress, then they go under anesthesia, they make a little less progress. And so just know that these patients are stressed, their systems are stressed, and the families are stressed even more. And I know this lecture is not about the management of the care of patients' families, but honestly, the communication and the care of the patient's family is nearly, if not more important than the patient itself, so that the family can understand. No family member, almost no family member understands the ICU or the processes of which we do. And so it needs to be explained to them who the quarterback, Dr. Marchand and I were taught a lot of our polytrauma care by Dr. Higgins, who gave a lecture every year called The Care of the Multiply Injured Patient. And he so clearly went through that you need to describe the hospital system to the patients in a way that they're relatable. And a lot of people know football, and explain that the quarterbacks of the team are the general surgeons. We are not the quarterbacks. We may be running backs, wide receivers, tight ends, whatever you want to call it. But the quarterbacks of the team are the general surgeons, and you start to label who all these people are, and people start to understand what's going on more. If you can care for the patient's family, it goes a whole lot for the patient itself, because then the family is maybe a little less stressed and can care on the patient itself. So just be aware of that as medical students and orthopedic residents. That's something you can very clearly describe to patients because you understand the system. They don't. So here we go.
I
We have
mean, even to build on that real quick, the patients may be intubated for the first week. Like you're probably talking more to the family than the patient themselves, you know?
totally, totally. I mean, this guy was intubated for, almost a week and a half. So,
Yeah, exactly.
all right, we're going to quickly run through these. We do respect your time. So we're going to talk about one specific thing of pelvic trauma. So here's a 22-year-old male. He has a blood pressure of 88 over 54, heart rate of 121. Here is his, he undergoes his airway and breathing is okay, but here is his AP pelvis. Dr. Scamitzi, what do you want to do for this patient?
Yeah, I think the things to notice on the AP pelvis is that he's got an APC pelvic ring injury with a traumatic disruption of his pubic symphysis. And this is a volume expanding pelvic ring injury, and he's got signs of blood loss and some hemodynamic changes. So he's hypotensive and tachycardic. So I think the important thing to do from an orthopedic perspective for this patient quickly is to get him in some type of binder or sheet to close down his pelvic ring and close down that potential space and improve his hemodynamic status. I think preferentially I prefer a sheet. I think it's a little bit more soft tissue friendly. I think we talked about that a little bit, but sheet over binder just 'cause I think it's a little bit more gentle for skin and soft tissues.
So I guess based on the question that was asked, if this guy had a lateral compression variant injury, are you mad if they're in a binder?
Like they came into the hospital from EMS with a binder, and I'm not mad.
Yeah,
I think
yeah.
like we mentioned earlier, I think if they're hypotensive and tachycardic in the field and there's a blunt injury, they're concerned about a pelvic ring injury. I think like we said, it can cause some discomfort for the patient, and maybe it'll exaggerate the deformity for the period of time that the binder's on, but not mad if they're just trying to save a life. I think it's reasonable to do that in the field.
Yeah, we're talking about, at least in reference to that question, like often in the field, somebody's hypotensive, very reasonable to put a binder on them. They're not going to know what the pattern of injury is, so it's irrelevant. And then even when they're in the hospital, I mean, I'm probably not going to be mad if somebody's really hypotensive and they're dying that you put a binder on an LC injury, but you just want to get an X-ray in the binder and assess and then take it off if you see it as a lateral compression injury. Probably going to IR is going to help that person more than the binder, but it's not something that we're going to be extremely upset about in general, I'd say.
Totally. I have no issue with the patient being in a binder with a lateral compression injury and it being completely internally rotated. I don't think that that causes significant harm, more so than you are not going to cause more displacement than the injury caused. And so I think that in order to save a patient's life to come in, I think it's totally reasonable to keep people in binders. And then as you see the pelvis and as the patient stabilizes, you can then start to work these people out of binders appropriately, but I have no issue with them going in binders. So this patient here, Dr. Scamitzi wants to put in a binder. Here we go. We put him in a binder. Do we like this? Yeah. Okay.
See,
Definitely improved.
Team loves it. So this patient has a thoracic blunt aortic injury, a descending thoracic aortic injury, pneumothoraces, pulmonary contusions, pelvic ring injury, and a left ankle fracture. His blood pressure now is 125 over 81. His lactate's 2.5. pH is 7.3. These are numbers that are very appropriate for definitive care. But do you want to take this patient for their pelvis first?
Nah.
I think the aortic injury probably takes priority. You want to preserve life first, and that's the thing that can kill him fastest. So um, probably that needs to go before the pelvis.
Billy, this patient gets taken emergent to the OR by vascular surgery for a TVAR. They reconstruct the aortic arch. And then once they're stable, they undergo definitive fixation of their pelvis. But they're stable in a sheet, and that can stay on for a little bit of time. There's nothing that we need to do definitively. The aorta needs to be fixed. Okay, lastly, we have one more consult. We're running out of time, but we have one consult left. Night float is coming to an end, but you get one last trauma one. This person is crushed by a gangplank. He's a 67-year-old male. He's at the docks and he's crushed by a gangplank that fell off a crane. Here are his chest x-rays and his pelvis. You notice that he has a volume expanding pelvic ring injury. He has an intertrochanteric femur fracture. He has an enlarged heart. He's 67. And you go down to the trauma bay and you find out that he's 405 pounds. He's 6'3". He's on dialysis. He's type 2 diabetic. His lactate's 7.3. His base deficit is 22. His pH is 7.03. Dr. Marchand, is there, what do you do with this?
So those radiographs are concerning, primarily from a volume expanding standpoint and also a soft tissue standpoint. No part about this case and even the temporary management of this case is going to be easy at that size. I'll tell you right now that something that sticks out is that base excess lactate. Anytime your lactate gets over 5, your mortality shoots through the roof. And when it gets over 10, it's darn near impossible to recover from it, even if it corrects, if it just makes it above 10 for a period of time. So, certainly alarmed about this person, their comorbidities, their body habitus, and this injury. It's worth a crack at a binder. If the binder doesn't work, and the patient's clear, you're talking about probably an X-fix. So here's a sheet. It looks like not a binder. Same idea. Well positioned. Those clamps are just above the graters, which means a majority of the sheet is centered at the graters. And you're not having a significant improvement in that pelvic volume. So for me, probably that's not going to do the trick. This is a check-in with anesthesia, general surgery. Can I do something more? Will this patient tolerate another 30 minutes of surgery to put an X-fix on the front of their pelvis?
So IR comes in. That's the next step. You put a binder on, still needing blood transfusions, still hypotensive, goes to IR. I'd be lying if I knew what the squigglies meant. Sometimes the blushes look like blushes to me, but not to the IR folks, and sometimes it's the other way around. Almost always they buy themselves a little bit of gel foam, maybe a little curly Q. But this patient went to IR. They said they didn't really find too much. They weren't able to coil anything, but he's still requiring blood in the OR. He's still slightly hypotensive. And what are you guys doing from here? Angio negative. This is the radiograph you have.
Yeah, you got to close that pelvic volume down somehow. So X-fix probably.
So he gets an X fix. I think one thing to take home from this for the medical students as you go is this is by far not a quote unquote reduced pelvis, right? The symphysis is at vastly different levels, but what we care about is the volume of the pelvis. The volume of the pelvis has been restored back to its fairly normal status. And this patient, as soon as the X fix was put on, stopped requiring blood transfusions. His blood pressure went up and was able to be taken back to the ICU and stable and critical, but was not requiring blood transfusions and was stable. What I can tell you though is that the patient with the 4 extremity polytrauma and a lactate of 13.8 went back to work at 6 months and is I've seen a bunch. He has a family of 2 and he's back to working. This patient unfortunately passed away. And so polytrauma is a real thing. We are not perfect. We can't save everything. We try as hard as we can, but unfortunately, in this field of medicine, we do have some unfortunate outcomes, and we try our best, and that's why we're continuing to try and get better. But even despite some of our best efforts, we aren't able to save everything. So know that not all the outcomes are warm and fuzzy. Any last words for the group?
Thanks for putting that together, Pat. That was awesome. Greg, can't thank you enough for joining us and your wisdom. We appreciate it.
Yeah, thank you guys.
Thank you guys. That's it. Hope you guys learned stuff. Next week we'll be doing, or next month we'll be doing open fractures, talking about how they're different than closed fractures, some management stuff from that. So we hope you join, and hopefully you have a good rest of the day, rest of the week, rest of January, and we'll see you guys in February. Thank you guys so much for your time.